So let me talk about briefly what we did here. We did something called a decompressive craniectomy. And I'm sure you've heard that. But the whole idea there is to literally, I kid with my residents, we pop the top of the skull. We basically take part of the skull off and let the swollen brain relax. Now there are pros and cons to it, like anything we do. We immediately relieve the pressure when we take the bone off. And we minimize secondary injury. It's this idea of taking brain that is already compromised so that it won't push on the brain that is still working. Now there are downsides. There are studies that suggest if you do this decompressive craniectomy, you can actually worsen, in the short run, the swelling right around the area that's decompressed. It's like taking a dry sponge and dropping it in water. It's going to swell. And that brain, which you've taken the bone cover off of, can swell outward and start to pinch against the bone that remains. But at the end of the day, if you're faced with a brain that is swollen during surgery, you can't put that bone back in. I mean, you don't want to pull out your shoehorn and try and help that. That's not going to help. So in the end, that's what you have to do. And that's what we did. And let me just sort of show you graphically what we're considering. This is out of a great paper produced from the wartime experience in Iraq, talking about decompressive craniectomy. And obviously some of those injuries are very, very severe. And these are the different types of openings of the scalp you can use to get that access. You have to open a large amount of scalp so that you can open a large amount of skull. Although sometimes the injury itself, the bullet wound, the blast wound, guides which incision you use. But then you're left with the actual bone opening. And again, this can be tailored to exactly what you need. This is much more similar to what we were considering in this case. And again, the theory is sacrificed brain, or the brain that is injured might be sacrificed by this approach, but you're trying to save the good brain beneath. You want to keep those pressures under control. And this is what you're left with in the end. A little gruesome, sorry, you just had lunch. Those of you who chose the vegetarian option chose well. But we open the lining of the brain, as you can see there on the left, and then we cover it, because we're going to close the scalp. Obviously, we can't leave this open. It would be infected. We close the scalp, and at some point, we'll have to go back and replace that bone or put a prosthetic in place. That prosthetic can be basically crazy glue cement, methyl methacrylate, or titanium, or some of these very new plastic high-impact polymers. But we have to replace it. Not only will the patient have an area of exposed brain that becomes sunken after a while, but there's actually what we call the syndrome of the trephined. A trephination is an opening of the skull. And we know that patients recover their function and their cognitive ability much faster when you put the bone back. The brain does not like to be exposed to atmospheric pressure. The other surgery we did, which didn't get quite as much notice, was about a week later. So when I first talked about the Congresswoman's injuries, I mentioned that she had the gunshot wound to the left side of her head. But what really didn't get a whole lot of play was the fact that that same injury caused fracture lines across the skull, fracturing the left eye socket all the way across to the right eye socket. Now fortunately, the left eye socket, the bones were well lined up, nothing to do. But the right eye socket actually caused the eyeball to protrude a little bit and needed to be decompressed. We waited for a week because obviously you don't want to exacerbate the brain swelling. The brain takes precedence over other things. But basically, a week later, decided it was the right time to go back, take those bone fragments and that pressure off and repair that. And that's a skull-based approach, and that's actually something that I am most comfortable with. That's what I am, a skull-based surgeon actually, most of the time for brain tumors and things like that, but occasionally for skull-based trauma. And a basic principle of skull-based neurosurgery is more bone, less brain. I can always take a piece of bone off and put it back, or a prosthetic, but if I pull on your brain too hard, if I retract too strongly and I damage the brain, I can't fix that. If I damage a nerve, I can't fix that. So that's a basic principle, and that guided what we did here. An interesting side note, though, when you think about it, is that bullet shattering the left side of the skull, but then across to the right side, really tells you about the force of that bullet. But just as importantly, it tells you that the force of the bullet was transferred to the skull, and I'll tell you that's far more preferable than transferring it to the brain. Again, more bone, less brain. So what we did was an orbital osteotomy. And basically what that means is take off the eyebrow bone, work along the roof of the orbit, retrieve those bone fragments, do the repair. In her case, we did an eyebrow approach. And this is a pediatric journal article that basically summarizes that. And the reason for that is because we didn't want to have to take the chance of opening the scalp all the way across and exposing that brain that was still swollen and quite angry, and potentially risk compromising it. So this was a clever way to get to where we had to completely across on the other side of the skull. And the last procedure we did, that again got the least mention of all, is called a ventriculostomy. This is a very common procedure. A lot of neurosurgical and trauma patients get this. It's basically inserting a tube into the deep fluid spaces of the brain. We can use that to measure the pressure of the brain and then to drain that fluid to make more room and lower the pressure if it's a problem. In the Congresswoman's case, pressure was never a problem, thank goodness. We were actually more concerned about draining some extra fluid spaces which had developed as the result of the craniectomy. And my understanding is that since she has arrived in Houston, they were able to pull this out. No need for further drainage. This is a simple procedure, but it is life-saving.